video conferencing unit, similar to what you're seeing here. On top of it is a highly specialized camera that can zoom in so that the person can have a really close-up view of the person that they're interviewing or taking a history from. In the right-hand corner is what we call our general exam camera. And that camera, we use it a lot in dermatology. It can like zero in on a lesion, so you could like do surgery on it. I mean, it's like really microscopic, high definition type camera. We also use it to look at somebody's throat, that kind of thing. On the bottom right-hand corner, on the far end of your screen, is our intraoral camera. That looks like a toothbrush, a camera in it, and take high definition pictures of the teeth. In the middle is one of our ENT scopes. It's an otoscope. Again, you can see by the image there, really high definition of the eardrum. That's what it's showing there. And in the upper left-hand corner to your left is our stethoscope. You can transmit heart and lung sounds using a telephonic stethoscope, and they're very good sounds. Pulmonologists use it, cardiologists accept that. And I want to include EMR systems in telemedicine because it really is part of telemedicine as we all go to EHR, and we have implemented a eClinical Works system. And there's actually two types of technological applications to this. One is called Store and Forward, which you'll see the picture of the teeth. You can actually take that little toothbrush type camera, take a picture of the teeth, and email that off to a dentist for screening, or obviously x-rays, and they've been doing x-rays for years. Digital x-rays are being read. When you go to the hospital and have a chest x-ray, it's probably being read by somebody at the other end of the globe even. And then we call that Store and Forward. And then the other application is called real-time video conferencing, similar to what we're doing right now. And I'd like to talk about 2 R's, because everybody asks about this in terms of reimbursement and regulation. I'll start with regulation. For a provider to give a telemedicine consult, they need to be licensed in the state that they're giving the patients in. As I said, there are standards of care which are followed, and it's really an enhancement to what you do. It shouldn't replace what you do. It's an enhancement of what you do, and patients should always be given choice of whether they would like in-person care or telemedicine care. It's been shown to be as effective, but it is a patient choice. And of course, it has to be HIPAA secured and confidential. And the reimbursement is coming. Medicare is definitely paying for consults. Medicaid in our state has just started to pay certain clinics for the consults. This would be a direct reimbursement to the provider given the consult. And other private insurers in our area are also reimbursing. So it is coming. It will come. In this time of health reform with all the emphasis on HIT, it's bound to come. So what have we done at Figure Lakes? We've actually done several different telehealth, telemedicine applications. One is diabetic retinopathy screening. The other is ENT specialty care, teledentistry, telepsychiatry. We've done distance learning and our EMR system. And I thought I'd share with you just some processes of how we started, how we planned, what we used, how we did it, where we're headed, and to be honest about the lessons we've learned, because it is a new thing, and although there are other people who've done it longer than us, it still works out. Whatever you're working within your health center, there's still processes to learn and things to do as we go forward and implement change. So the very first thing, Sandeep and Mary found some funding for us back in 2007, and wrote some grants and got the equipment going, hired the staff, picked out the priorities that we wanted to do. These are the sources of our grant funding. And then, from a project management perspective, and I gave you some handouts, we're looking at doing pulmonary next. And, just in terms of documenting a process to be able to communicate with management and providers and all the people that you need to coordinate with, just to have a plan in writing. First, to identify the work scope. What is pulmonary? What does that mean? What are we going to be doing? Who are we going to do it? How are we going to do it? Answering all those questions, and I gave you an example. And then you have a development team who actually does the planning. These are high-level CEO, CIO, COO your directors that actually will plan on, where are we going to put this equipment, who are we going to hire, that whole development work plan. And I've given you a copy of that, of some of the specifics, ideas that you can think of in developing a work plan. And the third one is actually the deployment. This is when you get actually ready to implement. This is more clinical staff you'd want to involve at that point. Your office management staff, your providers, your interpreters, anybody that's going to be interfacing with the patient and that equipment. You want to get them in so that they're educated and involved. And then after you implement, the most important, and I think the hardest part, is the quality improvement, where you have to just stick with it. Every month you have a meeting and you talk about all the things that are still either on your task list, or what went well, what didn't go well, what do we need to change. That's the most important part of it. And of course documenting so that it can be replicated. So I want to tell you a little bit of a few clinical scenarios. We started doing tele-ENT, and we had an ENT provider who was a specialist that we actually did consults with using live video conferencing. And does everybody know what ENT, ears, nose, and throat doctor? I actually went and spent clinical time with him and learned what he did in his office so that we could, because we have to be his hands, ears, eyes, everything, right, remotely. So I went and learned what he did, and we did several consults. The best story, I'll tell you in a minute, but how you can use this application is for specialty care consults. Say you have a kid with chronic ear infections, or someone that's got sinus that may need surgery, or you could even use it in acute settings with someone may have something stuck in their throat, that kind of thing. That would be urgent care. They can do the initial consult, but they can also do a pre-op evaluation, and then even if the person has surgery, all the post-op care can be done remotely, as well as any other follow-up visit. This is some of the equipment we used. Again, in the left-hand corner, you can see the live video conferencing system. Down below it is a picture of an eardrum, and it's literally the picture that the doctor sees, and you can either do that in real time or forward it to them. The equipment, there's several different areas of equipment. One is very high-end equipment that's more expensive, and with a specialist like this, you do want to use the higher-end equipment. But for just general exams on maybe somebody at the daycare that needs an ear exam, you could go with lower-end equipment and still get very good images. And lots of it looks like just like your otoscope. You would look in somebody's ears and nose with. And here's what the literature says about this. Studies done in the United Kingdom and Australia looked at otolaryngology exams, at the ENT exams, done by telemedicine in the area of post-op care, head and neck cancer, and pediatric consults. And the literature said throughout all the studies that I had reviewed, it's cost-effective, it's feasible, it reduces travel, making for a greener planet, one article talked about. It reduces unnecessary transfers to higher-level centers, and there's high patient satisfaction. And again, the images are comparable to an in-person assessment. I'm just going to tell you real briefly about a lady that came to our clinic. She was a 56-year-old woman, was new to our clinic, had been referred to us from the emergency department. She was uninsured. She worked at a convenience store, making maybe $8 or $9 an hour. And she came in with vertigo, which is severe dizziness. And it had really impacted her work because she had to bend over and stock shelves, and she would fall over. And she went to the emergency department, and they treated her with medication, and she just wasn't getting better. So our primary care doc saw her and recommended an ENT consult. And we had Dr. DeChico, as our ENT doctor at the time, came onto the screen, and he said, okay, Terry, I'm going to talk you through. I was the telepresenter at the time. I was actually with the patient doing the history and physical for the doctor on the screen. And they're going to talk you through an Epley maneuver. It's like, oh, I know about Epley maneuvers. I've never really done one. Okay. And what happens in vertigo is sometimes people get little stones in their labyrinth in their inside of their ear, and affects their balance. And you have to move those stones with these things called an Epley maneuver. And basically, the person lays on the stretcher, and you have to rotate their head one way, and then they sit up. And there's these maneuvers you basically just do with the head and neck. And he talked me through that. And she got up, she felt 100% better, called her the next day, the symptoms were gone. I mean, it's just like really, really great. And you know, our program not only did it increase care for her quickly, we also helped her in terms of financial. You know, we basically paid for that visit, reimbursed the specialist for that. And it was just very effective, and she was happy, and she's been with us ever since and talks that whole program up well. We did run into a problem with malpractice insurance with that particular private provider. He was a provider that runs a private practice, of which we're going to have to do some talking, probably with New York State. So malpractice is one issue to always think about when you're doing this, and to clarify with your providers. I don't know why just that, but it just is what it is. The other area that we've been working with is telemental health. And again, this is doing real-time consultations with a psychiatrist. These are patients that are in our clinic that, you know, have symptoms of depression, or maybe they're bipolar, schizophrenic. They're followed by our primary care doctor, but access is a real problem. They can't get appointments at our mental health clinic for 9 months because it's a county mental health clinic. They're on Medicaid. It's just, you know, really hard for them to access care. So we've contracted with a psychiatrist who works with us, and he actually works with Deb Cole, who's our clinical social worker, and she telepresents the patient to him, because Debbie's been seeing them in counseling for some time and knows the patient well, and you know, he basically recommends treatment changes, mostly medication management, for our primary care doctors to implement with him. So that's been really successful, and it really helps patients with access. Again, Debbie or he, Dr. Lilly, could do psychotherapy if they chose to, and you know, they can also meet with our providers anytime to talk cases. We have a provider that does Suboxone treatment, which is treatment for substance abuse. You know, just the fact she could consult with a psychiatrist in her care delivery would really help the comprehensive care of that patient. So again, the literature says, let's see, a systematic review of the literature was published this year in the Journal of Clinical Psychiatry. 620 articles and 10 random control trials covering over 1,000 patients were reviewed, and these were the results. Increased access was achieved, clinically effective, it's face-to-face, it's cost-effective, there's decreased time to treatment, high patient satisfaction, and it is an effective way to manage medication in conjunction with the PCP. So here's what we did. We actually started this last April, and I went back and did a retrospective chart review for the first quarter of when we had implemented this. We implemented it at one site. We're waiting for expansion in our other sites. We need to build more space in some of our health centers, because you have to have a very special room. It has to be quiet. It has to be confidential. You can see Deb's in that room. She can shut the door. You know, it's not a busy clinic area. So we're waiting on our other health centers as we do expansion to put in more rooms so we can expand the services. Anyway, these 6 referrals, the diagnoses were post-traumatic stress, bipolar depression. Mean time to consult. In other words, the time that the referral was made to the time they saw the doctor was just over 2 weeks. That's like incredible, when normally it's 6 to 9 months. The mean time to treatment, some of them were immediate. It was like right after the consult, you know, they were on the phone calling the prescription in, the patient, but the mean time to treatment actually was 4 days. No hospitalizations yet. That is one outcome we're tracking, because we are screening if people are in need of emergent care, if they're suicidal, for instance. We do satisfaction surveys with a high score of 5, meaning highly satisfied. And you can see our patient scores were 4.77, which we're very happy with, and our presenter scores were around 4. We had trouble with our broadband, so we were getting a lot of freeze up and turn offs, and it was really funny because the patients didn't care about that, and the psychiatrists didn't care about it. But Deb and I were like, oh, but it still did not impact the patient care at all. And in the meantime, we've now upgraded our broadband, and we are absolutely having no problems. It's really almost perfect. Our other area we've done is diabetic